Here with the ReadyStick ultrasound ECMO simulation, and I've got a clear neck and a clear chest here to use today. The operation would be very similar with pigmented parts. It's just a little easier to visualize in clear. I'm going to start by connecting my jugular vein and carotid artery to the barbs on the chest, just by kind of pushing them up and snaking them over. Until it's always seated. And I'm going to do the same thing with the other vessel. Once those are set up, I'm going to go ahead and push my two bases closer together, at which point I can take my rotational locking mechanisms and drop those into place, making sure these are aligned. And then with a clockwise twist, you'll feel them start to tighten up and lock in. And once both those are in, the base is secure and will function as one solid piece. I'm going to take a set of fingers and pinch on the barb and pull these vessels tight. I don't want this kind of kink in the vessels, but I'm going to give them a pinch while I'm pulling just to make sure I don't accidentally slide those off the barb. And now I can go ahead and place my two manifolds to cap the ends of the model. The uneven manifold will go up at the proximal end towards the neck. And I can go ahead and once again slide the fittings or the hoses over the barbs. And then the Y-shaped manifold will go down at the distal end. And this just inserts directly into the push connects. And I can give it a solid push, make sure that those are all the way seated in there. And the model is now ready to go, ready to be primed, ready to be operated on. Now the model is ready to be primed. So I've got a 1,000 milliliter IV bag full of blood, as well as a collapsible IV tower. This has a concave and a convex side to it, as well as two straight sides. So make sure you're aligning the right side. If you're going to attach this to your base, you can simply slide the tower towards the concave side and pull it up, and then lock it back into place. It's easiest to prime at max height, so that's where I'm going to leave it for the time being. I'm going to go ahead and connect it right down here, and then set my IV back up off of it, and connect it to my distal manifold. Now I can go ahead and open up the IV bag and open up the proximal manifold. I'm just going to open one of these to let air escape the model. And I should start to see flow through the model. You can put an angle on this if you're looking to give it some help. You can also actually raise the IV bag up off of the tower to get some extra pressure to start to prime this, but you will see the fluid, in this case I'm using our blood solution, start to flow through the model and fill it up. You can actually see it fill the internal heart cavities, and then I start to get bleed out from the proximal manifold, at which point I'm going to close that off, lower my bag, and I can see a rather large air bubble right in the ventricle. That is somewhat expected. Again, you can kind of combat that by tilting the model somewhat, but in this case, we're going to use a little cheater trick to pull that bubble out. Now that the model is halfway primed, you can, once again, see that trapped air bubble in there. You can also, if it helps, take any sort of flashlight to visualize and stick it under or beside the model to illuminate, again, that air bubble or the filled vasculature. So in this case, I'm going to take the easy approach and locate the dimple in the model just towards the bottom side of the left pectoral. And I can take a long, thin needle. This is a 22 gauge and I'm just going to actually aspirate the ventricle. So I'm going to pull as I start to back the needle out. Let's make sure I got it actually deep enough in there. Actually got a lot of air in there in this particular instance. But again, I'm just aligning with that dimple, as that is the highest spot on the ventricle, so it's going to retain air for the longest. And I think with one more pull, maybe two, just making sure I'm going entirely vertical. I can no longer see a bubble within the chest. And that's critical for the quality of your scans. The other easy way to do this would be to use your probe. This is kind of critical if you're working on a pigmented model. And you can actually directly scan the ventricle from above and see there's no trapped air in there. Now that the model is primed and ready to go, we're going to go ahead and take a look at some of the anatomy in the chest. So we can actually see the right ventricle all the way from the tip through the tricuspid valve to the right atrium, which we can track as well. And so you can see that entire heart anatomy represented right there. You can also take a look at the tricuspid valve in short axis. You can see where the leaflets come together there. And you can even watch it pulse if you have a lumen blowing across it or are doing any sort of compressions on the model. Now I'm going to go ahead and move up to the neck. Where I can scan my jugular vein and carotid artery. If you wanted to operate, you could go ahead and insert a needle at this point. You're going to get a little bit of bleed back, set the bag to whatever height you want, depending on how much you want that bleed to happen. Now I can go ahead and start my guide wire. Which I should be able to track on my ultrasound, so I can see it right there. I can actually follow this all the way down the chest. Into my right atrium. Again, following the tip of the wire there. And I want to ensure that it makes it down into the IVC rather than going through the tricuspid valve and into the ventricle. So I can see again the tip of the wire is in my IVC there. And I'm even going to push it through. We've got some simulated hepatic veins that branch out, so I'm going to make sure it doesn't get caught up in any of those. And once you're happy with the position of your guide wire, you could again remove the needle and insert your cannula or dilator. It's not necessary to dilate the tissue prior to catheter insertion, but if you were looking for practice, you could. You can also use a lubricant if you're using a catheter with a rougher surface, something more likely to get caught, or something on the larger side. We provide some soap for just that purpose. And I can watch again. This does not have any tracking in it, so I cannot scan it reaching the atrium. But if I were able to, I could show you that, as well as I could show again, if this were a lumen cannula, I could show flow. This does work under Doppler, and you can see the tricuspid valve move. To extend the lifetime of your product, I recommend removing your catheter as soon as you're done with whatever operation you are working on. You don't want to leave that in, as it will stretch the tissue out. It's also important to note that while lubricant is advised, we do not advise using any sort of incision to widen up the initial needle puncture to make that access any easier. I'm going to go ahead and scan the spot where I just stuck that dilator, just to show what the tracking looks like after that. But as you can see, even such a large device does not leave any significant, there's a very minimal track there. But this is plenty ready to be reused. The tissue will last about 20 sticks. The vessels last 5 to 10, depending on the size of the device and the aggression. So that's that. At this point, you would want to drain, flush the model, and you'd be good to set up for the next one.